get you in trouble for all of our opinions.
That's cool.
Yeah, he knows the
We're
deal.
live. We're
Yeah, we-
live. So I'm in my house today. Lisa is once again not in her house. Today, as you can
No.
see, she is in a hotel somewhere in Arizona. And allegedly, the air conditioner needed to be turned off, and she is going to boil while we're talking, which is exciting. So, whatever. Whatever.
Cat.
Um,
Once
Every
again,
time.
your
It's
your
only when we
internet is
start.
already broken.
It's only
It's
when we start.
literally.
You are fine. You are fine till we go live. Every single
Right,
time.
that's what I said. This is like a real, it's like an infrastructure problem. I think everybody
You
in
need to
Atlanta goes
move.
on the,
You need to move. You need to move. It's done. You got to move.
If
Sorry,
the
bud.
hotel works better than your house, that's a bad sign.
Yeah,
that's
this
what
is
I'm saying.
literally like
Every
not a very nice hotel. No offense to this hotel, but like their internet is working. Yikes, girl.
is she frozen? Oh, she was
No.
hot.
I don't know what to tell you guys. But you know what? It always comes right back like 1 minute after we start. So I'm like confident in that. Dr. Jasen Gundersen, would you please quickly introduce yourselves to our loyal fans before we send you backstage to avoid liability?
Sure. Hey, everyone. I'm Jasen Gundersen. I'm the CEO and co-founder here at CardioOne. I like to kid with everyone. I was a doctor. I mean, I still am a doctor, but I hung up the stethoscope like I think 6 years ago now. I'm starting to feel old when I say that, but
Do you miss it?
some days, yes, very much. Some days, not so much. I fly a lot, so I actually doctor in the air like a couple times a year.
Shut
Yeah,
up. You when they call for help, you're like, I guess it's me.
I
Shoot,
worked as an ER
that's
doc and a hospital
oh,
based doc, so
oh,
they usually ask
okay.
for like, "Oh yeah, we'll take you." So
Yeah,
yes,
they're like we got a
That one.
pathologist and like a derm and you.
it's selfish because I want to get where I'm going, and I don't want like no offense to like a dermatologist or a psychiatrist.
Wow.
Sometimes actually, I think you probably need psychiatry more than me sometimes on the plane. But anyway, I've been kind of working with docs my whole career, and founded this little company, CardioOne, 3 years ago. So excited to hang out with you all.
Nice.
Yeah. Well, loyal fans, you're going to have to wait for all the exciting things about, we don't even know where Jason is located. But Pooja, we do know Lisa is in Arizona
Yeah,
right
Pooja,
now. We're
it's
very
me.
excited.
It all just came together. I'm at the Arizona Health Law Summit, and you're also here. So I'll text you later.
Yeah, so many
I'm here
nerd
for like
shows.
24
Okay,
hours.
Jason,
Exciting.
we're going to keep you safe in the backstage. Melissa,
Yo.
we're going to keep you safe too.
Oh, cat. Oh my
Okay, well,
goodness.
whatever.
I'm gonna drink
Everybody's
this
used to it.
this cold brew in a can and just see how far it gets me.
Oh, she came back. Oh, there she's gone again. Okay. Well, anyway, in case you guys couldn't tell from all of our exciting announcements, this show is sponsored by CardioOne. We are very excited to talk to Dr. Jason, medical doctor, retired.
Oh, medical
And
doctor in the skies.
yeah, so we're making up what we're gonna talk to him about like right now, legitimately, but this guy keeps cardiology practices independent, which is interesting because no one's keeping anyone independent these days. Maybe Farzad is a little bit. So we're gonna see what's what. We're gonna see how that happens. And
I don't
apparently
think
he
it
has
made it into your news show, but I'll add that on to the end of the news show talking about that. So keep going.
oh,
Keep
oh,
going,
I'm very
cat.
excited. Do you want to start
Mm.
with that? Because we'll forget.
Well, yeah. I don't
Yeah,
know all the
start with that.
details, and I'm not going to Google that quickly, but Aledade, as folks may know, they're a VBC enabler. They work with primarily Medicare Shared Savings Programs, ACOs, and they try and keep, doctors and practices independent, but give them some kind of like underlying infrastructure and support to be successful in MSSP. And that's been Farzad and Aladede's thing for a long time. And they actually it was just like announced or whatever came out in the news that they are raising like a gazillion dollars in debt financing related to, as far as we can tell, like the delay between CMS announcing the ACO shared savings results and like how long it takes them to pay it out. And they're actually using the receivable from Medicare as like the basis of that financing, which is apparently like a novel thing to do, to be like a government receivable as the reason why you can raise that much debt financing. I don't know. I don't know. I mean, who knows what it's exactly related to, but It is true, I will say, that the government is like extraordinarily slow in paying, those like shared savings or like calculating and grabbing those like shared losses or whatever for risk-based arrangements like ACOs. It's interesting. And I don't know if it means anything bigger about Aledade or if they really are just like, we really want to pay practices sooner, which is again like a legitimate criticism of the, Medicare shared savings program and all of the ACOs that takes government like multiple years to be like, you did good or you did bad, and here's your money for doing good, and here's the money you owe us for not doing as good as you should have. And, I mean, there's been some discussion, I know from our friend who is now in charge of Medicare, Chris Klomp, about how they could potentially just generally pay providers who accept Medicare
Yeah.
faster. And, like that's an issue, right? Like if it takes years to figure out like you did a good job or you did a bad job, also not great.
Yeah, that's a big gap to float. Speaking as a
Uh-huh.
business owner, that's like not
Yeah,
ideal.
yeah,
I don't know.
yeah.
I'm not a finance bro, Lisa. So I don't know what that means. But if they're using it to pay their practices faster, like or help them bridge the gap, that's
I
cool.
may have
That's
made that
nice.
part up, so just like don't quote me, but no one record this or ask me any questions. But I feel like
Would
I don't know if
record
it's
this.
That's right. That's right. Shh, shh. Don't talk about that. It's either like they want to pay the reward to the practices sooner, or they're having trouble floating all their payments because it takes so long for Medicare to pay stuff. So if you know, feel free to chime in, tell me I'm dumb, whatever. It's all
Yeah.
good.
Go in our comments and tell us we're
Go in the
dumb.
comments.
We're just
Yeah,
some dumb girls on the internet just saying
that's right.
stuff. Okay, well we'll
That's right.
figure that out. Maybe our special guest knows some stuff on that.
That's
Yeah.
right.
Okay. So a lot of stuff happened this week. Some of it all related. So Dr. Susan Monarez testified in front of the Senate Health Committee on Wednesday. I watched most of the whole thing while my cat's home mobile vet came to give them their annual shots. And Yeah, I thought Susan did a great job. I thought I say her name wrong, Howery, Dr. Deb Howery.
Deb Horry, I think. I don't
Howery.
know. I don't know
We're
pronouncing her
saying
name.
her name wrong. Also, pretty much
Sure.
everyone on the committee also said her name wrong. So anyway,
I
I
believe
thought
that.
she did a really great job. And generally, it seemed like Dr. Menarez was framed pretty positively in the press, which is not us, by the way. We're not the press. We're just, on the internet. But the greatest part of this, I thought, the part that I was actually able to pay attention to without my cats getting in their little papooses, was Senator Mark Wayne Mullen accused her of being a child who was dishonest and said that there was a
Yikes.
recording of the meeting. This was like just so awful. I thought it was like such theater. And then I was like, Susan, like, kind of, or I should say, Dr. Menares kind of sat up straight and said, it repeated what she has repeated the whole time, that no, this is in fact what happened. I didn't tell him I was an untrustworthy person. And he said there was a recording. And then it turns out 50 or 30 minutes later, someone from HHS said there's no recording.
Yeah, listen, everyone, I want you to all just take this to heart. In this day and age, a lot of stuff is recorded, whether you know it or not, whether it's legal or
Like
not.
the talk show, like the health tech
Like the
talk show.
talk show, which apparently is recorded. Someone didn't tell me this little fact that you can watch these shows back. Damn it.
Oh my
But like
gosh.
you should just know that like the likelihood you're being recorded in a business meeting by like an AI or whatever ambient scribe situation, if you're in your doctor's office and you're having a visit, like there is a good chance that it is being recorded. And I don't feel like that's great, but also like it is the reality. And so, yeah, I mean, people should just assume that this is happening. But if I were, in fact, a US senator and I were in any kind of situation where I had to, like, be on the record and like swear on a Bible or whatever, like I would be careful. I'd be careful.
Might not say some of these things, especially because, like, oh man, if
There are
there
like
is a recording,
evidentiary rules. Yeah, there's like rules about submitting evidence. Like I would be careful. I'd be careful.
if there's a recording, I would love to hear it because there's all kinds
Same
of
girl.
wild things that people definitely said in that meeting. I would just like to hear it. Like, I
I'd
would
like
just
to
like
hear
to
it
hear
too.
all the
Sign me up.
accusations. Oh my gosh,
Sign me
release
up.
the tapes! HHS, release the tapes!
Yeah, release the tapes, guys. You know what? Let's be truly transparent. Let's do it.
Commitment to transparency in America. I am here for it.
That's right.
Anyway,
That's right.
so this hearing, whatever you believe, if you believe Secretary Kennedy's version of events or Dr. Menard's versions or any of the versions in between. That is not what we're going to talk about now. What we're going to talk about is what happened as a result of public perception of this hearing. And that's that there are a lot of people who appear to be, surprise, stressed that they will not be able to get vaccines for themselves or their children. So the ACIP meeting was yesterday and today. So right after this hearing, there was a lot of people who are stressed out and concerned about some of the things that are going on. Are they going to take away vaccines from Americans? Are they going to make access more difficult? And so a few things happened. As a reminder, this entire committee was wiped out and everybody was replaced who all generally share Secretary Kennedy's vaccine skepticism. So this is what happened in short order. Yesterday, they voted to make a controversial change to the administration of the MMRV. So that's MMR and varicella, the chickenpox vaccine. They voted to make that change, but there were some other weird things to it, like if it's still covered under the Children's Insurance Program, blah, blah, blah. Then, this is the same thing. Then they were like, wait a second, we didn't know what was
What
going
did we
on.
do?
We didn't know what the rules were because they're all new and no one really knew what was going on.
Yikes.
Know what they were voting on and what that meant. So they reversed that vote, and then they postponed the Hep B vote, which was highly discussed. So hotly discussed in the Dr. Menard's Senate testimony. So they were
I
like,
feel like this means nothing changed, right? Like it's very confusing, but I feel like it means
well,
nothing
like
changed.
nothing changed except
Okay,
there
great.
was one thing that late breaking. They've decided to no longer recommend the COVID shot. It is an individual decision, but
Well,
I
that's perfect
believe.
for you. You're in favor of that.
Well, here's
Perfect.
the thing. They already recommended it to me, and I already said I got God's vaccine, which is I live in the South and I get COVID every month. Like I already have my own individual decision making.
Yeah, you need to speak into your mic. You sound like you're on the moon.
Oh, well, I might be. Well, maybe I'll replace
Jesus
me.
Lord.
I
So
know.
complicated with this one. Melissa, you need to just Melissa, I feel like you just need to
I'm coming in here to
you need
say
to go to
I'm
her
going to
house.
buy you
Exactly.
like
Yeah,
an
go to
extender,
her house,
Okay, hold on.
sit her
my
down.
phone. I can only do so much. Guys, please remember that we accept sponsorship, donations, funding of any sort. It would originally have gone to a one,
Oh,
but now it will go to Kat and her internet. So
that's
please
right.
feel free. healthtechshow.com, sponsor us. No money is no money. All money is good money. So even if it's $5, put it into that account. There's a cute little
Oh
picture.
my God.
It's great. Go ahead, do it.
Amazing, amazing. Perfect. Thank you, Melissa, as always.
I was really trying. I even bought some fancy equipment, but it didn't work. So here
I know. Okay, so individual decision, yay, they whatever.
Sure. I feel like everybody knew what I was saying here because I've said it 1 million times, which is I already before this decision had the individual choice, the freedom to make my own decisions about the COVID shot, which is I am fully vaccinated for the original one. And then I kept getting God's vaccine, Lisa, which is I live in the South and I got COVID every month. So like I never needed a booster. So I always
I
said no.
consider the boosters to also be God's vaccine. Kat, as a
well,
famously
what I'm saying.
non-religious person, God was directing the hands and the mind of those scientists when they created the updated vaccines, and therefore it is also God's vaccine. You're welcome.
Okay, I agree. That is also God's vaccine. I'm just saying, according to CDC guidelines, for a while, I actually haven't checked recently. They were like, for a while, they were like, listen, if you got the Rona recently, like, you don't need to get this.
They don't that's right. That's right.
I was using my brain and my freedom of choice in America.
That's right.
Anyway, but the
right.
point is, like, I don't really even know what this means. I think also, Lisa, this probably also means nothing. Because I think I have to read, there were a couple other articles that came out that said they've voted for insurance to still cover the shots. So basically, this means nothing.
It's one specific program. It's like the Vaccines for Children program, which is a thing that covers like a baseline of childhood vaccination, just to really triple, double, triple, quadruple ensure that all kids can get childhood vaccines without any issues around insurance. So there's just like it was like a special side program, but yes, that's what they did.
Can I just say one more time? I think I talked about this a lot when I originally got God's original vaccine twice. Shout out to the Fulton County Department of Health in Atlanta. They made getting the vaccine so fun. Like there was like music. They gave me presents at every turn in the line. Like they high-fived me. They gave me stickers as I
Smart.
walked out. I mean,
Super smart.
They made me a freaking t-shirt, Lisa, and a hat. And you better freaking believe I came back and got more presents the second time. So I do feel like, in general, high five Fulton County Department of Health, high five all of our local public health authorities. And we should make vaccines cool again. Like, I feel like there's a branding problem here. And I don't know, maybe someone wants to hire us to figure, I don't know, we'll see what's going on. Anyway, so the point is nothing changes, but everything changes and no one knows. And there's a lot of confusion. Meanwhile, there is a lot of confusion and there's a lot of negative public sentiment about some of the changes going on, allegedly. And we also heard, if anyone who's not us listened to the secretary's testimony in the Senate Finance Committee a couple of weeks ago, there was a lot of conversation about this gentleman, David Geyer, who is a vaccine skeptic who believes vaccines cause autism and has been, I guess, given some access to some data, some older data, and was about to get new data. And this is all very controlled. If you read the article, apparently there's a special terminal within the CDC in Atlanta where he gets to access some of this data. The meeting where I guess he was gonna get newer data got canceled. He got no-go'd. So
I wanted to read you a important quote, which may come up in a future event that you're hosting. It is difficult to get a man to understand something when his salary depends on his not understanding it, by Upton Sinclair, of course. And that's how I would describe this dude who has been hired to find a link between autism and vaccines. And the other way around, vaccines and autism. There you go. Listen, if you hire someone, you're like, this is your job. He's gonna do it.
Like I think to be clear, we are biased people. You should not hire us to do things.
Do not hire me to do this.
Biased.
Hire someone who is neutral. It's not me.
Yeah. Also, I don't know. Seems weird. Anyway, I applaud the individuals who decided to cancel this meeting. Hopefully it was for more than just scheduling conflicts, but I don't know. I think scientists are real, Lisa. Like I think they're real. I'm not one of them, but I think they're real, and I think we should get some of them to do this work. I don't know.
Totally.
Anyway, like we said, meanwhile, America is confused. The public is confused. There's fear, uncertainty, and doubt about vaccines. Lots of parents are getting their kids vaccinated, and it looks like, according to this data investigation from NBC News, that many communities don't have the herd immunity levels needed to avoid getting diseases that'll kill us all.
Yeah, so like back in the day, not too long ago, like something like 30% of kids would just like die before age 5. Like just like die, right? Of like all kinds of things that are totally preventable through like sustained vaccination and herd immunity caused by that. Like there's like so many things that are like one of the things people used to die of was called summer complaint, which was basically like kids drinking spoiled non-pasteurized milk like in the summer. Like
Summer
just like
complaints.
literally it's called summer complaint.
Wow.
Like there's so many things that are like really fantastic that we've done from public health perspective, like clean water, like non-contaminated food, and like vaccines. Those three like killer pair there, they just really solved a lot of problems for us, and we don't have 30% of kids dying before age 5 or whatever the actual stat is. Don't quote me once again. But like yeah, it's just a bummer, right? Like speaking of like technology, like that's the baseline, like clean water, uncontaminated food, like vaccines to eliminate like just basic like diseases that have been plaguing people for like, come on, I don't want polio, just like Scott was just saying. We don't need this.
I don't want polio either.
I
I
don't want
think that
polio, man.
sounds really not great.
Yikes.
I don't know.
Yikes.
Like, I mean, well, the bummer is, and we talk about this all the time, Lisa, is like the FUD campaigns, like the you're being stupid because you're listening to the man conversation. It's actually really effective, unfortunately. And like, yeah. Also with like people who you just have a baby, you don't want to screw up your baby. The baby looks healthy. The baby is in your arms. Like, and then someone says, oh, if you get this baby that Hep B shot right now, definitely going to make it autistic. Like that's scary.
Right.
That's scary stuff. And like, my kids are 11 and 13 now, but like, I heard those arguments, like, right. Like as a professional in the world, like those are the arguments that I heard. Now I did have a water birth the second time. So I was surrounded with some interesting individuals, but like it's scary stuff. And it's really unfortunate that that's the move. But anyway, I don't know. Hopefully, I mean, again, everything and nothing happened at the ACIP meeting. So maybe that's a good outcome.
Yeah. And just to be clear, obviously, all of the medical specialty societies are like very clearly like making recommendations and trying to fill the gap and be like, no, like please do. We beg you. We are pediatricians. We swear. And
Yeah.
AHIP.
Okay. Also, I want to say I criticized the AAP for not showing, like they are no longer participating in the ACIP meetings, and I was like, "Fuck those guys! Like, show up at the table. Like, at least have your voice heard." I do think they should have their voice on
What's
the record.
the boycott? What is the boycott like achieving in that case? Like, you should be
Yeah.
there.
But I also like I will say I do think they should show up, but like their advocacy right now and the way they're getting the word out to the communities. I mean, they pretty much every pediatrician on the planet, well, in America, is listening to the AAP, whether they're in that meeting or not. Their messaging's pretty good. So I do wish they would show up just so they could be there, because I think there's a bunch of other groups that were on the record saying like, whoa. And Lisa, I think as you noted, you sent me an article about there's some hot mics in that meeting, because I guess everybody's so new they didn't know their mics were hot. So like they caught people calling people an idiot. Yeah, I showed up like kind of midstream yesterday, and someone was saying like, "Oh, hey dog, how are you?" And I was like, "What?" So yeah, I guess maybe the next few meetings will be better. They were, as reported by the real media, very disorganized. So anyway, yeah, AHIP put out this statement saying like all of our members are still going to cover your vaccines until the end of 2026, regardless of ACIP's recommendations. So that's like good.
Yep, and Kaiser Permanente here in California said that they are literally making all the vaccines available to everybody over 6 months with like no questions asked. Then there are also like states where, like in Massachusetts, where the governor has directed the health commissioner to just like put a standing order in for like all residents of Massachusetts. Like, there's states are doing state stuff, right? They're like, cool, gotcha. Can't depend on the federal government. States' rights.
Yeah, states' rights. God bless America. I mean, again, I am pro freedom in all things. I think if you want a vaccine, get it. If you don't, like, don't. But that kind of was how it already was.
Yeah, it actually was. And that's the thing. Like, any argument of like, oh, it was trivially easy to get an exception, and some people were like mad they had to be like, I have a religious exemption, and I'm like, okay, but like it's not that big of a deal. Just it was not impossible if you were like, I decline.
Yeah, I don't know. Anyway, so it sounds like everybody's going to start doing this. Your great state, Lisa, has joined up with others in the Pacific Northwest to have their own vaccine coalition. So the states are going to be states, so that's exciting.
Sweet.
Good piece of news I think for everybody. I mean, it's definitely, I think, good news. The Support Act reauthorization was passed by the Senate yesterday. Senators Cassidy and Hassan. I would say Hassan, but it's Hassan, isn't it?
I think so.
Yeah, whatever. They pushed this through. It was already passed by the House in June, I think. So those of you who remember the Support Act Part 1, this was actually something I thought the Trump one did really well. They supported a lot of work around funding for individuals with opioid use disorder, trying to reduce overdoses, which I thought was cool. And so this has been reauthorized. It's a little bit, it's obviously not the same exact thing as what we saw in Trump 1, but there's some really good stuff. There's some funding for a lot of communities that are rural and have had a lot of funding pulled. And even not rural, right? The cities, the big cities, Philadelphia, I know has a whole lot of different programs for opioid mitigation, New York City, Chicago, all that. So this applies to anyone, not just rural communities, but I'm really excited about it. And I'm looking forward to Lisa writing a long blog post on the LinkedIn that I can read and understand more about. Just saying.
Yeah. That's my big plan.
Speaking
like
of
this.
long posts that Lisa writes that are very informative and everybody loves, CMS, again, we talked about this last week, but they've launched the Rural Health Transformation Program. There was the first of 2 webinars today for the states, but anyone could go. So obviously I went and kind of paid attention. There's a lot of details. Lisa, tell us more.
Yes. So remember how HR1 passed and the OBBA, and we were like, oh my God, $1 trillion has been cut from the government and all the states and everyone is going to suffer. And they were like, don't worry, we have a rural health transformation fund and it's $50 billion. So this is now the launch of that. And basically it's $50 billion. It will not make up for all of the cuts, of course, but it is important. And it's important in particular to states because they have like 5 minutes to get this done. Basically the way it works, it's only 50 states, no territories are involved, and DC is not involved. Every state gets basically $100 million. 50% of the funds, $25 billion, is like apportioned across 50 states. So every state has some kind of rural population that is not DC, I guess. I guess this is my ignorance. Please don't like murder me, Rhode Island or Delaware. But I wasn't aware of your extensive rural population. If you were from Rhode Island, Delaware, feel free to throw things at me.
Well, Lisa,
But sure.
NYP is a rural hospital.
NYP is a rural hospital.
So,
I know. And actually, really quick side note in my own monologue here. NYP, so Stacey Richter, Relentless Health Value, amazing podcast, and the show yesterday was from the police union guy in New Jersey. Really great conversation, and he was like talking about how the hospitals all like advertise to people, right? And then that same day, I got a reel on Instagram from New York Presbyterian from someone being like, oh, it's so great that the New York Presbyterian gives all the moms who give birth here a Chanel gift bag. And I was like, are you effing kidding me? Like, it's not great. No, it is not great. Nonprofit status, whatever. Sidebar.
Yeah.
Okay, back to the Rural Health Transformation Program. Every state gets 25 billion, is like broken up between the states, $100 billion, it's 5 years. And then the rest of it, the other 25 billion, is going to be basically apportioned to the states by CMS based on different factors in the application, including like the rurality of the population, the situation of the hospitals, blah, blah. So they all have to apply, all the states, even for the baseline funding, and they have to not mess it up, and they have to do it by November 5th. And they have like no time. It's out of control. So all the states are scrambling right now. And they're working really hard to like get their applications together. And they've almost all put out like RFIs or like questionnaires on their websites to be like, please, people of our state, like tell us what to do with this money. And so it's going to range from there's a list of things. It's going to range from things some are going to spend it on providers, some on technology, some on whatever. So just like worth checking out. Scott put a little link there, the Rural Health Info Data Explorer. There's a whole variety of things, including my LinkedIn post from yesterday. Feel free to check it out as well. It's an article about the program.
It was pretty good.
Thank you.
Yeah. I initially was like, wow, CMS is so mean. But the timing within this program is actually like a law. It's in the
correct.
OBBB.
Correct.
So yeah, they're just the CMS team. It looks like they have the new Office of Rural Health. They have been trying to figure out how to get this done, and also, I don't know if everybody remembers like the tobacco settlement money that people didn't use for like tobacco related things or even healthcare things. Like I know they also are trying to make sure this isn't just slush fund money, right? That doesn't have guardrails. So based on what I heard in the webinar that was at 3 Eastern, it does look like they've been really thoughtful trying to figure that out. But I mean, it's just like
It's really
really
hard.
hard.
It's a lot of money, not a lot of time, a lot of requirements, applications. Like it is, and then it's 50. There's 50 of them. Every
Yeah.
single state right now is like, shit, we have to do this right away. So they're
Right.
doing
It's
it.
really tricky. And then most
Mhm.
likely it looks like once states are approved and they've received whatever funding they get, then there are going to be a ton of different procurement processes or moving money to existing public-private partnerships. And it's just going to be a lot. It's a lot for people to figure out. So anyway, stay tuned, listen to Lisa on the internet. And then our friends from, so I know the Sirona people. Also, my bestie Andrew Van Ostrand totally now is working at Sirona Strategies.
Yep, as of like a few days ago, I think.
Like I freaking love that guy. So that's exciting.
That's
Anyway,
great.
we like these people. They're great, and they form a lot of these coalitions. And I believe this is their newest one. Lisa, you probably know better than I do. But
I think this is it's a nonprofit coalition that they're part of, and they put together this summit, the Rural Health Transformation Planning Summit with CMS.
Yeah, so this is like, next week, the 30th. And send as a sponsor. There's lots of different sponsors. The states can all attend this. I believe the states get to go for free, but I don't actually know. So like, don't quote. Again, sad this is recorded because there's like
Pretty sure, yes.
Vendors don't get to go, but in person. But I think vendors can like pay some money and attend online. So that's exciting. So there should be a lot of good stuff here. The states get to have some dialogue, which is exciting. So that is great. And then last thing we'll say very quickly is the other thing states are super stressed about, work requirements. So in case no one knows, but I hope everybody knows, the states have a deadline of January 1st, 2027 to have systems in place, processes in place to actually accommodate work requirements needs for Medicaid beneficiaries. So that, by the way, is really freaking hard, y'all, because if you look in this little timeline here, the secretary isn't even releasing the interim rule for how this all works until June of next year. Yeah. And so states, but to be clear, states are already freaking out. This is a big deal. The state benefit determination systems are outrageous. Like a lot of them are custom built. They're old. Like shit is off the rails. This is actually really hard.
I think we mentioned this before, but literally what many of the states can do in this time frame, they said, is they can implement a 1 or a 0.
Yes,
a
no.
meets or doesn't meet, yes or no. And that is like, keep in mind that just the stupidity of the fragility of these state technology systems, like everyone, wow. Yikes.
It's really awful. And so it's also a little unclear. We've heard some rumors that that CMS will fund states to develop this thing. We've heard that that USDS is working on some tools that they can use. The problem is that there's 56 different systems here, right? I think it's 56, there's at least 50. And
56.
They're all different, and they've been built by different vendors, and it isn't just something that I think you can plug and play. But last time I checked, I'm not a technologist either. I am neither a scientist nor a technologist, so I could be wrong. So they'll release that in June. They'll release the interim rule, not until September 30th. There's not going to be a lot of time. Is what I'm saying here.
There's not gonna be a lot of time. States have a lot of things on their plate right now. Just a little plug for Lisa's other podcast. Check out the episode with Nikita Signoretti about Medicaid eligibility enrollment and the tech issues, because we talk about some of this stuff and like just the massive burden that exists already and is going to really exist with these new work requirements.
Yeah. And you see here, and this is from Kaiser Family Foundation, December 31st, 2028. Apparently, there is an option for the secretary to give a 1-year extension. We have heard from multiple states who have already inquired about that they will absolutely not receive an extension. So this is a nice thing to have in the text in the chart here, but it is not something that any state is currently counting on given the feedback they've already received. So scary.
That's great.
All right. Also, we're going to have this guy in the show. Lisa found this guy on Health Tech Nerds.
I don't think that he knows. Dr. Bensall, you don't know that you're invited on this
show. He doesn't know.
You will soon.
Melissa, will you tag this guy in a comment so he knows we're even talking about him? Anyway, he posted
That's
a
so
really
mean.
good and a really cool thread on the Health Tech Nerds, which everybody should join. I think it's like a couple $100 a year, but it's like the best, and it's where
So
Lisa
worth it.
tells me to get all my news, which is great. But they have a
Yeah.
value-based care network channel. And this guy had some really, really thoughtful posts. And so we're going to make him come on our show. We'll see when that actually happens. But also talks about like the life of a small practice. He talks about ACO stuff. I don't know, Lisa, you sent me some good stuff from him.
Yeah, he's super smart. He's like, you know, there's a lot of like false flags. There's a lot of like straw man arguments in the value-based care space. And, you know, he's like, please understand that the like fundamental framing is that fee for service equals doctors are bad. Like that we think about fee for service versus value-based care and we say, that makes sense because doctors are bad and they will just simply bill more services because they are bad. And he's
Yeah.
like, he's like, that's not a fair statement for all of these reasons. And there are so many important exceptions that like prove the rule. You know, it's just a very nuanced, thoughtful take about the quote unquote problems of the upstream drivers of health, the non-medical drivers of health that have continued to fall on, you know, fall to primary care, fall to the, you know, care settings, which I'm sure that our guest will talk more about in a moment. You know, that it just are make it so hard to be successful in value-based care. And then to plug another podcast of mine, the one that happened most recently with Dan O'Neill, we talk a lot about the additional administrative burden around value-based care today that also just, you know, like is relevant to the story. So Sudeep Bansal, Dr. Bansal, we are going to invite you on the
Come
show
on
and
the
hopefully you'll say yes. Hopefully you'll say yes. Smart guy.
He's
And
got
a podcaster with PCP
He's
Lens.
got a Substacky type of thing that I signed
That's
up for.
great.
He's got some really good stuff here. Here's two that I read that I liked. Lisa and I are going to speak at a conference in DC on Monday. She will be in yet another hotel and another late night semi-red eye flight. Everybody pray for her. Donate money to the Health Tech Talk Show because we will send Lisa to the spa with that money after we buy me better internet TBD. We're also going to health as previously stated. It's amazing. Oh my gosh. All right. Now it's time for our special guest. Thank God, because we had a lot to say there. Oh my gosh. Can we call you Jason or do you want to be called?
Oh, please call me Jason. No, Jason is definitely.
I'm thinking Doctor of the Skies also works. I like that.
Yeah, Jason's much better. I told you I'm not a real doctor anymore.
Okay. So your team sent us these wonderful screen captures. Would you like to talk about them or should we bring them back later? Also, here is your adorable team.
This is one of my groups up in New Hampshire. So I can talk about whatever. We can go back to our fancy slide.
Okay.
So
Go.
we
Yeah.
basically-
Tell us what you guys actually do. Yeah.
Yeah. So we are basically the practice management platform to help independent docs. Right. So basically all the non-doctoring things. So EMR, technology, revenue cycle, staffing, website, search engine, making sure we have an ultrasound machine, you name it. All the things that doctors don't learn when they go to medical school and help them, thrive and survive in today's environment. So a couple of things, doctors are getting gobbled up by every health system out there. Like, I don't know if you see it, it's like Pac-Man. They just keep getting gobbled up. And that is not good for us as a society. It's not good for us as patients because health systems are very, very expensive. So we work with independent docs to help them either stay independent or, in the case of that picture from our group in New Hampshire, cardiovascular specialists of New England, we actually took them out of a hospital employment environment and set them up in their own private practice again.
So like say, I know the answer, but I want you to say why it matters. Like why do that?
Because healthcare gets really, really, really expensive when we go into hospitals. Because hospitals bill all these funky things called hospital outpatient departments, and they get substantially higher codes and charges than
that's your attorney calling you and saying,
Yeah.
Stop talking.
Actually, I think it's it's UC Health probably figures out that I'm going to go pick on them for, like, I'll tell you, like I had an echocardiogram, right? It's an ultrasound of your heart. I had one done here at UC Health, and I went into what I thought was like a doctor's office. And I thought I was kind of smart and do this stuff. Do you know what they charge for that thing? $5,200.
Holy smokes.
For an echo. Now we do them in the office for like $300-$400. So as people have kind of gobbled everything up, access has gone down, prices have gone up, and the health systems just continually just raise the expense out there. So I think independent docs are where we need to go back to, where you can have a smaller practice and call up and get seen. And, you know, our docs see patients in 2 days of a phone call. Good luck if you call one of your local health systems. You're probably 6 weeks if you're lucky, and probably more like 2 or 3 months.
Wow.
So,
Yeah.
and our goal is, like, yeah, I heard you mention value-based care. Our goal is to move cardiology into more of a value-based care construct, right? Because we've done it in kidney, we've done it in oncology, we've done it in orthopedics, but the number one cause of death in the United States, we don't do it. And so we're trying to move there. One of the best ways to kind of move into value-based care is to have lower cost sites of care that patients and health system and payers and everybody else can access, where you're not getting a $5,000 echocardiogram.
Right. I mean, the only option, like, you can get people in for lower acuity care, like for preventative care.
Yeah.
And then you can also make sure that when you have to do something, you're choosing a site of care that is favorable in terms of the cost basis. But you
Yeah.
can't do that if there are no lower cost basis sites of care left, right?
Like our practices do all their own stress testing. They do ultrasounds and echoes, cardiac monitoring, virtual care at home. A couple of our sites have their own PET cameras, which is like the kind of the state of the art in stress testing. So we're able to do it like right in one site. You're not driving around different places for the health system. And so, you know, our goal is to really kind of build those independent docs. And we really set out to work with independent docs and help them stay independent, because a lot of them are like, this is too freaking hard. Like I like, it's just impossible. And so they kind of just roll over. And cardiology is probably the fastest roll up of any specialty.
Really?
Yeah, like 20 years ago, 15% of cardiologists were employed. 85% are employed right now.
Oh, wow.
So health systems have gobbled them all up. And so it's just not been good for us.
What about cardiologists doing more? I mean, I understand that there are plenty of cardiologists who do a lot of things that would be considered or covered under primary care codes or whatever. Like, what's your thought, and what is the thought of the practices that you guys work with around, you know, doing more of those things that extend across the ecosystem of different types of services?
Yeah, that's a good one. So here's the thing I think about, like kidney care was like, I think easier for people to carve out because they're like, well, you go to the dialysis center. So it's like, okay, carve that out. Oncology, none of us doctors that don't do oncology understand any of the drugs or anything.
Right.
Right.
Like,
You
cool.
break something,
Can't
you
do
get
that.
orthopedics. But for primary care, like, oh, some heart failure, some high cholesterol, like kind of overlaps. But in reality, primary care is overburdened and not doing a great job because we're really not moving the needle on heart failure readmissions or, you know, lipid management or some of the preventative stuff. And so what we really need to do is have earlier access from primary care. And then for patients that are low risk, you make recommendations and you send them back to primary care. And there's more of a symbiotic relationship. If you ask, like, especially primary care that's like managing risk, like in the value-based world, no one sends them to a cardiologist because the cardiologist is employed by a health system. So two things will happen. One, they'll charge you ridiculous amounts of money, which will blow up your value-based care program. And two, you will never see your patient again. Because once the health system gets your hooks in them, they're like, well,
they're gone.
And they never come back. So I think we've built this
Interesting.
I just think we built a system that's not symbiotic and doesn't really like work together. So our docs don't want to do primary care. Our docs want to manage risk and work in cooperation with primary care and the referral docs, or, you know, surgeons that need, you know, screening for high risk patients. Get them tested, make sure they know what they need, send them back. If they're high risk and there's a, you know, a lot of disease that they manage, then they'll manage that. But they're not out there trying to manage diabetes and everything else. So it's really about trying to find that relationship back and forth.
Yeah, I would be so true or false, we should put statins in the water. Go.
True.
Got him.
Really?
All right.
Yes, it's true. Cat disagrees, and I strongly agree.
So I personally, so I'm telling my personal story. So like one of the other kind of passion projects around like why I decided to do this was there were 3 areas. One, I was an ER doc in hospital. So I'm like, Jesus, do people not have any care? They just kept showing up in the ER in the hospital because they never had follow. 2, I saw all these other specialties that my friends were doing. I'm like, oh, we should do something. And 3, I'm a cardiology patient. So I have actually had to access a system. So I have terrible, terrible lipids. And so
Me too. I'm on statins. Yay for
I
us.
am on statins and Repatha and because I have LP(a). And I was very fortunate 12 years ago that my doc was like, we should check this. And I'm like, what is, I didn't even know what it was. And I was like a doc, right? And they caught it, but I'd be having bypass or I've had a heart attack by now.
Wow.
So that's where I think people don't get to cardiology until like, right, if you think about it, no one's like, I'm going to get, go to the cardiologist, make sure my lipids are good, my blood pressure is good, and like I'm in good shape. Most people see cardiology after they've landed in the ER and had something bad happen, like they're having chest pain or something. And so I do think that there's more preventative, cooperative work that we should definitely be doing.
Yeah. So, okay. So like, can I just say I don't like things in my water because that removes my choice as an American. Anyway.
Listen, facetiously.
You do like pathogens in your water, Kat, because, well, they're there unless you put other stuff in your water. Just a hint.
I am very much in that boat too, but I think people are not aggressively managing those things.
That's right.
And here's the funny thing about U.S. healthcare, and I'm going to steal from Peter Attia because I think he's explains this brilliantly. Like, you kind of walk along and you're like, I'm fine, and all of a sudden your LDL's like goes from like 129 to 131. You're like, oh, you have high cholesterol. No, it's a continuum, and like we need to start moving it. Like our system really relies on a diagnosis, and so we pick a number like your blood sugar is at a certain level. All of a sudden you're diabetic. Well, you didn't become diabetic in 30 seconds. You've been drifting that way. So I think it's this whole idea of like a lot of things we can do, we need to get in front of, right? Anyway, that's my thought on the lipid side. I think lower is definitely better.
Let me go back to cardio. Let me go back to CardioOne.
Again.
Yeah. I'm ready. Wait,
I
okay, fine, Kat, you
I was
go.
just saying, I was pro freedom. No, it's my turn. Okay. So you're saying, so when you go in, the biggest issue is, that patients they get referred out, the hospitals eat them, they never come back. There's a lot of complexity in billing and blah, blah, blah. But you're saying like the secret sauce is you help, because I know you have tech too. You're helping them find a network, those relationships where it is more of like a referral independent practice situation. Everybody's happy, costs are lower. Is that what I'm hearing you say?
We basically run the practice for them. Our goal is like, you cardiologist, you go be a cardiologist. We'll be your technology, business, finance, marketing, you name it, we'll handle it. Because one of the big things that I think people come at, one, no doctor gets trained. I know I'll say something that I'm sure someone will flame me for. Like, doctors don't get trained in anything business, right? Like, you go to medical school and they're like, they teach you all this stuff, and then you're out and all of a sudden you're like, I got to get a job and work, and nobody knows anything about it. And the system is,
well, you can get a job. You can get a job and
you go become
a hospital, and then that's what you do.
But to like start a practice, that's starting a business.
Super hard.
Like,
that's a business.
So
it's not like me starting a consultancy. That's like you have to like.
Oh yeah, it's very complicated. So we give them, we give our docs the benefit of a big system without working for a big system. So they own their practice, but they get all the same bells and whistles and tools and support. Like, we have people that do all the credentialing and the enrollment with all the payers, and we have people that do the technology and make sure all that stuff works. And so everything they would get there, but then they own their own business. And so it's really about trying to solve the issue that kind of drives people to becoming employed, or, docs are just thrown like, I'm done. And so, it's build the wraparound. And then if you have the right tools and the right access, your practice will grow and thrive and flourish, because people will refer patients to you. Patients are going to come look you up because you've got a great reputation and you've got all the testing. And, oh, by the way, if you have a 20% copay, you're going to save thousands of dollars by doing it this way than going to the health system.
Yeah. What I was going to say is, so just this is a sidebar that is relevant to CardioOne. So Innovator just acquired Story Health, which had a lot of work in congestive heart failure, but it's not the only chronic condition or the only specialty it
Right.
targets. Is specialty coaching, but started with congestive heart failure. So working with a lot of cardiologists, and the approach there is to have this, companion like app or service that's not in the cardiologist practice to manage and keep those patients as well managed as possible before they have to see the cardiologist again, to allow cardiologists to have those relationships with those patients, maybe understanding or expecting that primary care isn't there. And you were saying that one of the things that the folks you work with are really wanting to not continuously manage that particular patient, but want to get them back into that coordinated care with primary care. Do you guys offer any services or technology that assists with that back and forth?
Yeah, so a couple of things. So one, we will manage the high risk ones where we need to in a model very similar to like what Story and the rest do. But sometimes people go to cardiologists for like something like blood pressure, and they're there over and over. So I think it's figuring out what patients need to be in cardiology, what patients need primary care. We have our own virtual care platform, so we do full monitoring. So we do blood pressures, weights, all cellular based, and we do the wearable monitors, so the EKG monitors, like even up through continuous telemetry. We have nurses and the rest, and so our physicians can enroll their patients into one of our programs, and then one of our nurses will put them in a care management program, monitor everything, and put that back. Story is interesting. There's some other coaching programs. I've really, really strongly believe that those programs need to be integrated into the practice and not bolted on top, because a lot of people like to throw coaches, and like all of a sudden you get a call from like some coach for United, and they're like, Lisa, and you're like, who are you and why are you calling me? Like,
right.
And then you go to the doctor and they're like, oh, this coach did this, and the doctor's like, oh, and there's no coordination. So
You
we
got it.
have our own virtual care platform is what we call it.
Yeah. And I think that's important. But tell us more about the sort of technology side, because it's my pre-existing belief or whatever. My priors are that it is obviously incredibly hard as an independent to be part of the health IT ecosystem, right? Whether it's, exchanging data for referrals or getting data for your patients as they're coming into the practice, or understanding, where your patients washed up at an ER or hospital or whatever, that the more independent and small you are, the harder it is to be part of this ecosystem. There's incredible costs that are imposed by large health systems, by large EHRs. Like, tell us more about that side of what you guys do.
Interoperability. I call it the myth of interoperability.
Nice. Yeah, that's right. Keep going. We like that.
It's just all like this whole thing of like Epic's going to talk to you. It's like, no, like I have 3 Epic logins in Colorado, and they're all screwed up, right? Anyway, I won't go down the rabbit hole on that one, but we have our own tech platform.
Know.
We have our own tech platform called Rhythm, and so we're built on an Athena core. So we just put everybody on that. And so one thing that I will tell you is like everything needs to be integrated, because doctors aren't going to go log in to a whole bunch of other stuff.
That's right.
That's another thing that people are like, oh, if someone's going to log in over here, it's like, no,
they aren't.
Not how the real world works. So from the physician standpoint, it's one interface. It does everything. EMR, the billing, they can read their images on it, like ultrasounds and stress tests or whatever. They can order virtual care. They can get all the monitoring stuff back. So for the physician, it's one side, one login. I'm done. We handle all the interfaces, data, you name it, so they don't have to deal with it. So it's all set up for them. And then on our Rhythm platform ingests. I'm going to talk tech because it's a tech shock show. So we ingest like ADT, HIE hits. So like we can get a hit if a patient's in the hospital and like, oh, they're going to come out and need a transitional care visit. So our team will call up and set them up for the transitional care visit. Or we'll have them set up with blood pressures and daily weights, and the heart failure patient were like, your weight went up 5 pounds. What are you doing? And we make an intervention, get them into the office before, because if they hit the ER, they will get admitted. Like,
Yep.
that's it. And so we've kind of solved for that. So they get the benefit of a big national tech platform, and we have our own product team and programmers and people that speak whole programming language that I don't understand, but they're great at. And so we call it the Rhythm platform, and that has everything integrated. So they're one-shot working environment, which then makes them much more efficient. And then we'll use ambient scribes or whatever, and then they'll have all the kind of data feeds as much as we can get them, right?
Yeah.
Which is always the challenge.
Yeah. Shout out to Athena for actually being probably the most interoperable, like base EHR platform.
And
these
I
days.
practices love Athena. Like I sometimes hear bad things, but like overwhelmingly not. So
no, they've been very good to work with. And we've been able to kind of build it and evolve it. And, what we tell people, people are like, well, can we get this from the hospital? I'm like, if the hospital will send us a feed, we will integrate it, plug it in,
right?
Whatever. The question, the key word is if the hospital, right? That's, they don't, I mean, that's unfortunate because, right, they're really not motivated to do that because they're trying to, let's face it, control the referrals. And so they don't want to let that, they call that leakage. Right.
But Jason, there's policy tailwinds for you right now. There's, talk about, more pushes on site neutral, more things that there's a lot of stuff that's in the proposed rules right now that is really policy tailwinds for you.
Yes. So I sit on the board.
Great idea.
Sit on the board of it's a very long name organization called American Independent Medical Practice Association.
Cool.
And we do lobbying on the federal level, and actually we have state chapters as well. So we published a paper we commissioned Avalier to go out and look at basically independent, management services companies like ours versus hospital employment. The numbers are pretty staggering. And so you would save hundreds and hundreds of millions of dollars with site neutrality.
Wow. That's
the lobbying arm of the hospitals is so strong that it's a no-brainer. Like if you think about it, like one of our local hospitals here is always in the news. Like this one news guy just obliterates them all the time because they'll have people to be like, I went and got an MRI and I got a $2,000 bill. They're like, I don't know that. And this is this whole billing thing.
Yeah.
As patients start to see it and we get this, if we got this transparency out there, it is the same test, the same equipment, the same results, the same read. There's nothing different about the test. They just charge 5, 8, 10 plus times the amount to do it there. That is illogical that I struggle with it.
Well, I think the problem, I'm in the middle there, right? I agree, right? I think that there's a lot of things that would benefit from site neutrality, and there are definitely huge problems on the cost basis and the lack of transparency. But from my perspective, the logical conclusion here is the system is getting it's impossibly expensive overall. Like overall, we're very much at that point, and like we're getting to a place where I think ACU premiums are rising a huge percentage again this year, right? Same thing for all other whatever. So the cost of insurance is getting even higher. Firms will continue to not swallow those costs. They will absolutely continue to push more and more cost sharing on their employees, on their members, all about like everyone. And what that is going to mean is that more and more people are going to be exposed to the full cost of pre-deductible. I mean, I've been exposed to this for a long time, many years. I've had a high deductible plan, and that money is money that I pay. And it is very, very obvious. So the logical conclusion here is skyrocketing costs, major cost shifting in insurance coverage, major increases in premiums. So people are going to start to push back individually very hard because those costs are exposed to them. There's not a lot of coverage. There's not a lot of like masking of the cost. So I don't know. I think it's going to happen whether I want it to or not.
Well, I'm going to step on something else. Like someone's got to go look at the not-for-profit status. Like,
why do we talk about that all the time?
It makes me crazy. Like every not-for-profit I go by, they're like, we have no money. Like, and they're building They're spending hundreds of millions of dollars in our market. Everyone bought the brand new hospitals, like right and left. Like they're all over brand new, but it's like, okay, well, like the one
We always say that nonprofit is just like a different way to make money.
well, I just not for profit basically is hide my profit. That's what I call them.
That's right.
Hide my
Ooh.
profit. So anyway, I could drift
Well, Jason, we're like running out of time, but you were really fun. So I have one question for you, and then we have to like let you actually say stuff that you want to say. But so I think in something that your team sent over, it also said you help docs that got eaten by health systems get uneaten and start throwing things again. I mean, are these hospitals not coming for you?
I don't know that I'm like the world's most favorite human from the hospital side, but I don't believe so. Yes, we've extracted and liberated 2 groups already and working on several more. I don't think that we are overly competitive in the world out there. I think there is a world where we should exist and things that can and should be done in the outpatient environment should be done that way. We shouldn't be charging HOPD rates and all this other stuff. But patients are going to need hospitals. There's procedures that are going to have to be done in the hospitals. We need to be working together. But the hospital idea of just continuing to buy every physician that they can is actually not good for them. If they actually sat back and said, hey, we'll manage it, handle everything for you, and you run the hospital side. Like it used to be that hospitals ran the hospital and then the doctors were in their offices and they would come and go. Someone in the last 20 years, they decided if we buy everybody, we're going to control the world. So I actually think that there's a symbiotic way that we can and should exist. Neutrality, we're the fastest way to help them.
Yeah, totally.
I love that.
Agreed.
All right. Well, like, what do you want to leave our loyal fans with?
Well, all right. So to Lisa's point, go get your, be proactive about your health, right? I'm just going to throw that out there, right? Like heart disease and these things are not something, I mean, people kind of find out when all of a sudden they're in the ER, they're having a heart attack. No, I don't want to induce hypochondria here, but like, there's things you can do to make sure that you stay healthy. And then go look for your private docs. Look for those docs out there, those smaller practices. I know all the billboards have all the big systems out there, but check the Google reviews, call those practices. The smaller practices, you can actually get in and be seen. So we want to see more docs out there doing that. And I think if patients push for more transparency on costs, and it's my record, stop being difficult about giving it to my other doctor. And like, I probably was gonna say something I probably wouldn't say on a Friday afternoon, but like, it's my health. It's my, like, why am I fighting with you about like my stress test report? It should follow me everywhere. Right.
Totally.
It's not like you get pulled over, right? For a speeding ticket, they know everything you've done in that when they scan your license, right? But when a patient walks into the ER, I am literally shooting blind when I was coming out. Now, maybe it's a little bit better.
Did you see Melissa when you said that? When they scan your license,
I have a byline coming out, and I literally say the same thing, Jason. I'm like, you can scan my license and get my freaking. I agree, 1,000%. Thank you.
I have a Dropbox with all my records because when I show up to people and someone asks me a question, I'm like, here you go. Yeah.
Yeah.
But,
I mean, the police even know when I went to my last Utah State liquor store. So
yeah,
that's great.
I think we just need, the more people kind of stand up, and I'm starting to see that now, like take responsibility for their health and really go out and look for the opportunity and really push the systems for like transparency and what's right. Like the most doctoring I do is actually not on the airplane, is people calling me for advice. Like
for sure.
My wife's a doctor too, and the two of us are like constantly, we're like coaches for family and friends around how to get through the system.
Totally. I would say that's awesome, but it's probably not for your home life. One more question.
Yeah.
Jason, you're an ED doc. Why are all ED docs sort of insane and wild? And why are you the doctors that always like do other things?
Yeah. So
stress.
All different docs have different risk profiles, but the ED is chaos. You don't have any plans. People show up. And so ED docs are adrenaline junkies, just like trauma surgeons.
That's right.
It's like if people go do it like because you like I don't know what's going to roll in.
And then you get
Like,
bored.
you could just
Yeah.
be sitting there, and all of a sudden, all hell breaks loose, and
Yeah.
it's yeah. So it's kind of like, have you ever seen this guy that does all these memes, Dr. Glockenflicken?
Mhm.
Yeah, we love that guy.
But he's the most active. When you look at the specialties, you're like, yep, that's kind of how everybody comes across. So yeah, it's adrenaline.
Yeah.
Adrenaline.
Yeah, you all like skydive and have your pilot's
I race
licenses
motorcycles and do all
surf and yeah. It's like
There you go.
insane. I would say, like Lisa, our number one frequency in specialty is ED docs.
Yeah. Emergency. Yeah.
So yeah. Wow.
Well,
Okay.
Jason,
we
thank
like
you so much. It was awesome.
You
were
should
great.
come back.
I would love to come
Come
back.
to our shows.
Yeah. Okay. Well, goodbye, America. We gotta go.
Goodbye, America. Thanks,
Friday's
Jason.
waiting.
Thank you.
Thank you,
See y'all
Jason.
later.
Thank you for coming.
Bye.
Have a good one.
Thanks, Melissa.